And now, again, following this oration, we move on to the valves which you devised, the trick valve. And we have two, we now have started using it in India, and we have two presenters. My first colleague would be Dr. Karunakar Rapolu from our hospital in Hyderabad. He's done a wonderful case, a very challenging case. So he would be the first presenter, followed by Dr. Simi, who used to be our colleague in our previous hospital, and now she's the owner of a hospital of her own. So Dr. Karunakar, over to you.
Thank you very much, sir. Good evening, ladies and gentlemen. At the outset, I would like to thank Professor N. Khanna, sir, for inviting me to participate in this wonderful session and great conference of APVIC. So let's see how this technology is helping the people. This is my case. He is a 53-year-old male, a known case of hypothyroidism, rheumatoid arthritis, cholelithiasis. He had DVT in 2013, known case of cirrhosis of liver with decompensated liver disease. This is basically a cardiac cirrhosis. He underwent umbilical hernioplasty in the year 2013. Recently, in this pandemic, he had a COVID in March 2021. So he is a known case of severe TR with anasarca, and history of recurrent hospitalizations with congestive cardiac failure, with shortness of breath and fluid overload, basically from both the severe TR and cirrhosis of liver. He had few episodes of spontaneous bacterial peritonitis in the past. This time again he admitted to the hospital with severe pain abdomen under gastroenterologist. He diagnosed as a spontaneous bacterial peritonitis this time again, and referred to cardiology in view of heart disease. They requested us to do something for his tricuspid valve disease, because that is causing the recurrent hospitalization and that is causing the cardiac cirrhosis. So when we took the history, we went back and checked his files. We found that he had a severe RTA 20 years back with head injury. He underwent neurosurgery 20 years back. During that hospitalization, he had sepsis. So that sepsis caused the infective endocarditis of his tricuspid valve, which was initially mild. Then it progressed over a period of time to very severe tricuspid regurgitation. But when he was treated initially, when he asked about that valve therapy and all, nobody was interested to do anything on that tricuspid valve. As we all know, that is the common practice. So he was having functional class 3 shortness of breath with gross ascites, anasarca, and huge cardiomegaly on chest X-ray. And his ECG showed AF with controlled ventricular rate. He is on rate reducing agents with RBBB. His 2D echo we have done showed grossly dilated RARV with severe low pressure TR, with myxomatous mitral valve with mild MR, taps of 20 millimeters, good biventricular function, with enlarged RV sizes. We can see that here in the echoes, you can clearly see RARV are hugely dilated, and there was no coaptation of the tricuspid valves. It's a free flow of tricuspid regurgitation. So then heart team discussions, during the heart team discussions, our surgical colleagues refused any sort of surgery in view of his condition, his general condition with cirrhosis, with lot of ascites, with lot of hypoalbuminemia is there. So surgeons refused the surgical therapy, open repair. Then we left with only interventional options, which were very limited. So this is these are all various options in the tricuspid catheter landscape, transcatheter landscape of the tricuspid valve. There were some instruments like direct suture angioplasty and direct ring annuloplasty, coaptation enhancements in the form of clips and Pascal devices, and some wall replacements. These are all under trials. Nothing has proved superior over the other. And in these patients, because of the huge cardiomegaly and non-coaptation, other options are not available or not possible also in this case. Then we have narrowed down our possibilities on trick valve implantation, that is a bicaval implantation. So as Mr. Agreli explained, these are the valves. It comes in two separate valves. One has to be placed in the SVC and the other in the IVC valve. So it contains valves inside and polyester skirt to prevent the paravalvular leak. These are the Nidnal frames, cylindrical structures. So like any other structural intervention, we need a meticulous CT angiogram protocol. So in this also we have to follow a CT angiogram protocol, and we have to do the three-dimensional measurements for proper sizing, which is very important to prevent the paravalvular leak as well as the valve dislodgements and valve migration. So these are the various measurements we have done. So in the SVC confluence area, SVC level, at the mid-pulmonary level, all the levels, different protocol is there. We have to follow that. We have done, and finally we have decided that SVC of 29 mm and IVC size of 41 mm. And this is the very interesting 3D printing model of his heart. You can see very hugely dilated RA and RV, and with a lot of rotation of the heart to the left. But during the hospital course, when we decided about to go ahead with the trick valve, then patient developed severe intra-abdominal infection with pus inside the abdomen with a lot of loculations. Initially managed by interventional radiology colleagues. They have done a pigtail drainage, but when pigtail drainage was continuously coming out, they suspected the bowel perforation. So subsequently CT abdomen was done, which showed loculated ascites, malrotated cecum with pneumatosis. Some doubt was there whether that is the cause, and they suspected even appendicular perforation. And diagnostic laparoscopy was done by a surgical gastroenterologist. They have done the peritoneal wash, and adhesivolysis was done. And but even then, some small pocket was left. Again, pigtail was placed. So subsequent hospitalization, he developed recurrent LRTIs, recurrent pleural effusions, which was drained by interventional radiology colleagues. And he developed a septic shock episode. He was on multiple inotropes. He was intubated on ventilator. Then subsequently he developed AKI with renal shutdown. CRRT was initiated. During the total hospitalization, he had cardiac arrest twice. So when his sepsis was resolving and when AKI is improved after CRRT, we decided to go ahead with the trick valve implantation. Here in the trick valve implantation, right femoral vein we use for the main valve delivery, and left femoral vein we use it for our other interventional gear to be taken there for multipurpose catheters or pigtails to place, and to place the wire in the RA to loop it. So we use left femoral. 2 6 French catheters was placed in the left femoral vein, and right was used to deliver the system. So here the first step is we have to place the multipurpose catheter in the right pulmonary artery. So that is the one important landmark. So when we are placing the SVC catheter, we have to place our belly part of the SVC valve above the RPA catheter. So that is the one important landmark. So we place that, and next we are wiring the SVC for the valves to be taken there. Then when we tried to push the pigtail to take the venogram, the wire in the SVC was coming out. It was prolapsing into the RV. It was coming back, and somehow we could manage it to put the pigtail back into the SVC, and we have done the venogram. And you can see in this venogram, lot of reflux was going into the peripheries to the brachiocephalic veins from the RV. And we have done venogram. Then this is another important step here. So after placing, first one is the placing the RPA catheter. The second one is looping the wire in the RA. So that gives the idea where exactly the SVC RA junction is located and where exactly the IVC RA junction is located. and that's how it's very useful landmark during the intervention procedure. And this was done under TE guidance as a protocol. Nowadays some cases are being done even transthoracic also, but as a first few cases better to do under TE guidance. Especially this TE is very useful to place the IVC catheter. SVC catheter you can place it with. To place the IVC we don't have any other marker. So TE guidance is very important. Then after that we place the amplage ultra stiff guide wire in the right brachiocephalic vein and SVC. Then we are advancing the SVC wall. So this is when we try to advance it, it was wire in the amplage wire was buckling. So we applied some pressure and we made it straight and we put some tug on it, and then slowly we advanced the SVC THV of 29 mm into the SVC, and here you can see that we are placing that belly part above the pulmonary artery catheter. That is one important landmark. So after adjusting the final positioning with venograms from the peripheral shots, so finally after satisfying with the positioning, so we are deploying here. It takes a lot of time to deploy the valve, almost 2 to 3 minutes it will take. We have to turn slowly and clockwise, and we are rotating slowly, flaring the, you can see the flaring of the SVC. So during that we have to be very careful, it should not move. And the important crucial step is last we can retrieve this system even up to 80% of deployment. If you feel it's very high or low, you can still adjust, you can retrieve and you can reposition it. But once it has reached more than 80%, and it's difficult. So once we are very sure that the position is okay from the landmarks and from the venograms, then only we have to release the catheter. And this is the fully deployed SVC wall, exactly positioned according to the plan. You can see that the belly part is above the pulmonary artery catheter, and the lowest part is above the roof and at the junction of SVC RA. And after that we pull down the multipurpose from the pulmonary artery to the hepatic veins, and the hepatic vein venogram was done, and it's showing there is a good depth between the roof of the RA and the hepatic veins. So then again we are advancing the IVC wall. So after advancing we are checking that so here the skirt part is located, it's a 20 mm depth, so we have to be very careful. So if the vein is very close, you can go little into the RA, few struts you can advance even into the RA, nothing will happen, but the skirt part should not obstruct the hepatic vein. So slowly we are after final adjusting, we are releasing the wall slowly by mm, and slowly finally we release the wall, and this is the final valve release. And this is the final check angiogram of the after deploying both the valves, SVC IVC valves. There is no paravalvular leak either in the SVC or the IVC, and you can see that the very good delineation of the right atrium. And this is the intra-op TEE. So TEE is very important, especially for IVC, checking the IVC and checking the paravalvular leaks and all. So this is the wall there, and again this is the SVC part. So both valves are functioning very well without any paravalvular leak even on the TEE. And because it comes 28 French pre-mounted system, so pre-closure is a must, and we have to do pre-closure. So we have closed this with two pre-closure device, and very good hemostasis is achieved. And this is the final bicable implantation of the valves, nicely hanging SVC and IVC without any parabolic leak, without any migration. And this is the 3 months follow-up echo, and we can see that RV sizes are coming down slowly, and function is very good, good RV function. And we are planning one CT study at the end of 6 months. Thank you very much for your patient listening.
Challenging situation, the patient actually was pretty sick and not suitable for any other form of treatment, and many doctors would have actually left it there and not treated the patient so aggressively.